Well, now I'm here with Professor Mark Gillies out of Australia. He's a renowned, physician in the field, and as well, he has a remarkable sense of style. So welcome, Mark Gillies.
Hi, Matt. Nice to be here. Meaty mice.
Right.
I love you guys.
Oh, thanks, mate. Well, now, Mark, tell us about what you're wearing today, where you've got it, and what's that all about?
I'm going to have to check it out, but I'm pretty sure, yeah, it's Ted Baker, right?
All right, that's a good one.
Ted Baker's just great.
Yeah.
He fits me down to the ground. It's nice and light. You spill stuff on this and it doesn't leave a mark.
Okay.
It's amazing. And someone gave me a pink Ted Baker tie, so
right.
I have to wear that.
Right. So you could be drinking a pink Slurpee, spill it all over. Wouldn't
no
leave
one
it
would
dead.
know. Yeah.
That's great.
Just brush it off.
Yeah. Well, great. And now the fashions of the day in ophthalmic surgery and the posterior segment. What do you think are the trends?
No, we're not talking about trends today, Matt. We're talking about way back when.
Oh, that's right.
We're talking about back in the day.
That's right. We're going to talk about the 80s.
And it's not surgery, because I don't do surgery. It's going to be, we're talking about the 80s.
Yeah.
Medical retina in the 80s.
Yeah.
And the 80s were great for some, it was really cool for the punk and all that stuff, but oh my God, for medical retina, it was shit.
Really?
I don't know why I did it in the first place.
Okay.
You would go into the office every Monday morning and just start filling out blindness certification forms, because we know how common neovascular macular degeneration is. We see it all the time.
Yeah.
It's swamping the system. Just imagine if you didn't have a treatment for that stuff.
Right.
So people would go blind in their first eye, and they'd be very upset by it, and they'd come back every week to tell you how upset they were. And as we know, half of the ones who go blind in one eye will go blind in the other eye. It was really severe, and there wasn't much we could do. So the macular photocoagulation study at that point did the laser study, where they directly ablated classic membranes, classic choroidal neovascular membranes. And the outcomes in those trials were an avoidance of a 6-line loss of vision. So basically that's a 30-letter loss of vision.
Right.
You're practically going from normal vision to nearly blind, avoiding that.
Yeah.
So then as things improved in the 90s with the photodynamic therapy.
I was going to say with Nirvana, but okay, right.
Not Nirvana, that wasn't Nirvana either, but then you should a 15-letter loss of vision. Now we're looking for vision gains. But back in the 60s, what you were trying to do, you had a good result if you prevented a 6-line loss of vision. And it turned out that if you did an analysis, only about 1 in 8 patients who had neovascular macular degeneration could be treated in this way, and the recurrence rate was at least 50%, and it usually occurred on the foveal side of the laser scar. So usually you couldn't get the recurrence. That was often the case, and this laser treatment was very, very difficult. So you had the choroidal neovascular membrane. You had to ring that with about 200 micron burns, but often you were dealing with 50 microns between you, margin of error between you and the fovea. It was very difficult, and so a lot of people used to give retrobulbar blocks just to paralyse the eye, so nothing could move while you were doing this very challenging laser. Then MPS, to their credit, they tested subfoveal laser, which is where you just destroyed it, even though you knew you were going to destroy central vision anyway.
Yeah. And
everyone was a little bit nervous about that to start with, but you would wait until the vision dropped to 660 or 2200 or worse, and if the lesion was like a disc size, a disc diameter or less, then you would just go in and destroy it.
Yeah.
And actually we got some reasonably good results from that. I'd have to say I had some people who I did that to, their second eye got involved with the same process, neovascularization. They had photodynamic therapy, and actually the eye that had the subfoveal laser did better. So it wasn't, it was a very challenging treatment to prepare patients for.
Yeah.
This is not going to make your vision any better. In fact, you're going to see worse after this. But in a year or two, you'll probably see a bit better.
Right.
And if you don't have it as well, you'll have a smaller blind spot. Then we got photodynamic therapy, which it was better than nothing, but it was a difficult treatment to administer again. You had to do this infusion.
Right.
You had to wait. dress up with the hat and the glasses and all this stuff. And results of that were also, not great. It did slow the loss of vision. On average, 1 in 25 patients would have immediate loss of vision because it destroyed the macula. You get this nasty burn. 1 in 25 patients. That was really hard. You couldn't tell, but you might have patients with like 6/12 vision, and they walk out of the room 660 and they never get it back again. So that was photodynamic therapy, and then we started getting intravitreal therapy. Macugen, obviously, the first one wasn't that great. That was a specific VEGF 165 inhibitor, which was supposed to be just the pathological impairing.
So it kind of slowed visual loss.
But then we got the pan VEGF A blockers, and here we are now. I don't think the point is, I really don't think people have any idea, the younger doctors and the patients, how bad it used to be.
Wow.
It is so much better than it used to be, even though we have to work very hard to get these gains, but injections aren't as technically as challenging, and you're expecting to get improvements in visual acuity these days, which we never got before.
So back in the 80s, if you were to come to a show in retina, I guess it wasn't as commercial back then because you just didn't have the therapies that you do today. So if you were to walk into an exhibition hall in the 80s, what did it look like?
There was no pharma. There was no pharma support. There's a couple of people who sold lasers.
Right.
That's about it.
Right.
Yeah, they didn't have the big parties in those days.
No,
no they did not. There wasn't the money swishing around there is now.
Right.
But then, people were still very serious about it, and we did what we could. It was more challenging as well because we didn't have OCT, because diagnosis was much more difficult. You had to have angiography. You couldn't do it any other way.
Yeah.
And the interpretation of the angiograms, it was just fluorescent angiography back in the day. That was also quite challenging. Something that took a long time to learn.
There wasn't EURETINA back then either, was there?
EURETINA
in the 80s, it didn't exist yet, right?
Yeah, right.
So what did you
Before
go? What did you
dawn
have?
of time.
Imagine.
What meeting do we go to? No one was interested in retina.
Did people come over to your house and they just kind of hang out? Bring their pink glasses?
Oh, I see. We had a meeting.
Yeah.
Or just down the pub.
Right.
Yeah, about how shit it all was. Yeah.
Right.
Yeah. Anyway, it's. I have to say, I was a bit nervous about going to medicine, but I tell you, choosing retina, it's just been amazing.
Yeah.
It's just been such a fantastic journey for us, and we've all sort of participated in the clinical trials.
Right.
And we've had these patients who, when we did the Marina study, had a few patients in Marina, and we just, wow, this is a great result. This patient's actually getting better. Can you believe this?
Oh yeah.
And we thought, maybe it's an outlier, and then the results came out, and we all know that's all nearly 15 years ago now.
Yeah.
But it's been fantastic. It's been such a fantastic journey. But we should not forget that without all these interventions, it was the commonest cause of blindness.
Right.
Massive cause of stuff. And together with everyone in the field, allied health professionals, pharma, everyone working together, we've made an incredible contribution to alleviate human suffering, and that's what it's all about.
Amazing. Well, just to think of one more thing about the 80s, one of the things that I think of is Michael Jackson's moonwalk.
Oh yeah, I can't do that. Can you do that?
No,
I tried.
Well, maybe I can.
Did you want
I'm not going to tell you.
Okay.
I'll disclose at the next conference.
All right.
But was there a pivotal moment in retina history in the 80s when something like a moonwalk happened? And if there was, how would you describe it?
No, there was.
There wasn't.
No one was smiling in the 80s.
Okay, yeah.
Occasionally you'd get one. Occasionally you'd get a vessel that you could destroy it, and then it was all dry, it was all good.
Yeah.
But it was rare. It was
so
rare.
And in the 90s, was there any Smells Like Teen Spirit from Nirvana? Was there a moment of the 90s when something happened?
Well, we started injecting steroids in the eye, triamcinolone injections in the eye in Sydney in the 90s at the Sydney Eye Hospital, Southside Institute. I wasn't there then. But some of those patients seem to do pretty well.
Yeah.
And now we can see that probably it was drying out the intraretinal edema, which you have with subretinal neovascularization, especially RAP lesions, and those steroids can have a great effect, a great temporary effect, but we didn't see the long-term effect that we're seeing with the VEGF inhibitors. But we started seeing an inkling of what might happen when we started injecting steroids in the eye.
Right.
And that's when we first started injecting
Right.
In the 90s, steroids, that was the first intravitreal therapy by injections. They had the gain cycle via implant, but that's not really the injections. The first injections were steroids in Sydney in the 90s. So it was, and we were getting good results, short-term results from that. Didn't quite understand what was going on so well because we didn't have OCT.
Right. Amazing.
And now the anti-VEGF just took off. I think probably with some really good quality clinical trials, you could probably define a role for steroids, for neovascular macular degeneration, particularly eyes with a lot of intraretinal fluid you can't dry out. I think steroids can occasionally be helpful there. But time's passed for that. We're anti-VEGF now and we're moving forward,
Well, you know, Mark, if this retina stuff doesn't work out for you, I have a feeling you have a career in glass couture, so to speak.
Really, Matt?
So please come back to France anytime to start your new fashion house.
All right. Thanks very much. See you then.
Absolutely.
Always
All
a
the
pleasure,
best.
Matt.
Thanks, mate.